Welcome to another WakeMed guideline webpage and app, Quick Take. Quick Takes are short videos introducing you to new guidelines. Today we'll be discussing the prophylactic use of antibiotics following traumatic injury. Remember, the guideline webpage can be found at www.wakemed.org/SPG. It is mobile friendly and publicly accessible. If you haven't already, add it to your smartphone's homepage as an app. There are instructions on how to do so on the webpage itself. We've also added 2 new sections, including educational videos just like this one, and outside resources like the East Practice Management Guidelines, Western Trauma Association algorithms, Behind the Knife, Life in the Fast Lane, and EM Crit. Now, the purpose of this algorithm is to define when prophylactic antibiotics should be used following trauma. There are multiple teams involved in its creation, including trauma surgery, orthopedic surgery, neurosurgery, ENT, and pharmacy. Now, everyone has reviewed this document and they agree to its contents. Let's start off with a gunshot wound to the soft tissue. So no hollow viscous injury, no fracture. In this case, no antibiotics. You can wash the wound out thoroughly and don't close it. Similarly, for stab wounds to the soft tissue, no antibiotics are indicated. You also want to wash these types of wounds out thoroughly, and you can choose to leave them open or close them. If you do choose to close them, do so loosely. Chest tube insertion. Now, data has shown that the rates of pneumonia and empyema are increased following chest tube insertion in the setting of penetrating injuries. And so for that reason, we recommend the use of cefazolin in the peri-procedural setting. So 1 dose either immediately before or after chest tube placement. However, no antibiotics are recommended for chest tube insertion following blunt trauma or closed injury to the chest. This one's for the surgeons. For patients with hollow viscous injury, whether it be from blunt or penetrating trauma, who are taken to the OR, where source control is rapidly obtained, they should remain on antibiotics for no longer than 24 hours post-op. Open extremity fractures. This is common. For this, we use the Castillo-Anderson open fracture grading guidelines, so grades 1 through 3. For open extremity fractures, we want to treat for 72 hours or for 24 hours post-coverage, whichever comes first. When I say post-coverage, I mean when the patient's taken to the operating room, the fracture is washed out, and soft tissue is now covering the wound. For Castillo-Anderson grades 1 and 2, we want to use cefazolin. If there is concern for soil contamination, we want to add Flagyl. For Castillo-Anderson grade 3 fractures, go straight for Zosyn. Okay, the days of gentamicin are gone. If you're worried about saltwater contamination, you want to add doxycycline. Moving on to facial fractures. We all know that ENT docs love their Unison and Augmentin, and these are in fact the antibiotics of choice for treating facial fractures. However, it's important to know that most facial fractures do not actually require prophylactic antibiotics. So no antibiotics are recommended for nasal fractures, mid-faced fractures, closed mandible fractures, or anterior frontal sinus fractures. For open mandible fractures, antibiotics are recommended. And for displaced posterior table or frontal sinus fractures, antibiotics are recommended. Now, when I say posterior table, that means the backside of the frontal sinus, in which case you have direct communication to the brain itself. So in that case, we want to coordinate with neurosurgery. And finally, skull fractures. So penetrating brain injury should be treated with ceftriaxone for 7 days. Open depressed fractures, also ceftriaxone for 7 days. And no antibiotics used in the setting of basilar skull fractures, in the setting of CSF leak, or following the placement of EVD or ICP monitors. That's it for today's WakeMed Quick Take. Thanks for watching.